And both of you have touched on this already, but can you give us any other examples of where you've had to you have like an instinct to react in a certain way based on your experience with children, and you have to like check it and reframe your approach?
I think that in some ways has been constant. And yeah, it's just, I don't really know how to describe it. It's, I agree with Samir. It's unlike the ARDS that we're used to. So I think just being super conservative in terms of everything that you do. So very conservative fluid management, very conservative vent management. In terms of vent modes, I think that's probably been one of the biggest questions I've gotten from my colleagues who are concerned about when and if they get deployed to take care of these patients. And what I've noticed is there's no one vent mode that works for each patient. We have some on volume control, we have some on pressure control. One of our units is using almost exclusively bilevel. And I think what I've realized is that the vent mode that works on one patient is not necessarily going to be what works on another patient. And depending on who the attending is or who the respiratory therapist is when the patient comes in, whatever they're most comfortable with is kind of what you try. I would say I probably have half of my patients are on volume control, and we tend to use VC AC initially and then switch over to a VC IMV when they're ready to start weaning. We're trying to keep our peak pressures, and plateau pressures ideally less than 30, but we've certainly had some who have needed peeps of 20 and have had peak airway pressures certainly higher than I like to see, so sort of 35 and 40 transiently. So trying to switch modes if we can get their pips down a little bit. One of the modes that seemed to work yesterday really well was pressure control PSV, which is not one that I've used very often, but was working really well. So I think, to a certain extent, the RTs are a wealth of knowledge, and sometimes just going in the room and just sort of tweaking things and trying to see what makes that patient comfortable, because certainly what works for one doesn't work for another. So I think keeping an open mind, but also I think what I've tried to impress upon them is the wealth of information that is available to you, and that you're not on an island, and that, particularly if you're working with an RT that's used to taking care of adults, I completely defer to them. And if they have a suggestion for what they want to try, I'm all for it. And it's either going to work or it's not. And if it works, great. And if it doesn't, then you move on to something else. So we have not put all of our patients on one particular mode, and have not used one particular weaning strategy. I think you start with what you're comfortable with and then adjust it based on how the patient responds to it. We are essentially extubating everybody to heated high flow nasal cannula, 50 liters, 100%, and then weaning from there. When they tend to fail from extubation, they fail very quickly. So it's not usually sort of hours and hours or days down the road. It's pretty immediate. And so just making sure that you have your plan for reintubation. So, in the new unit with the pediatric providers, we have anesthesia there, and they have their whole protocol. They have a go bag that has all of their equipment and all of the medications in it, so that they just take it into the room, because anything that goes in the room then has to be discarded. And just making sure that ahead of time they have everything that they need. We are using glide scopes for essentially every intubation, so that they can stand a little bit further away from the head and face. And, the other thing too that we've tried to highlight for everybody, including for airway, is making sure that you take the time to don your PPE appropriately. And making sure that everybody on the team is appropriately attired before you go in the room. And that's true for code situations as well, like just making sure that everybody is safe and trying to protect all of the healthcare workers as much as possible.
Yeah, there's no emergency in a pandemic. It's like a statement that's everywhere. And so we've been very cognizant about that. things from an adult standpoint that I kind of forgot, I guess, is the length and size of the lines are so much bigger. So, I'm like, wow, a 20 gauge arterial line? Like, I forgot those arrow kits and how painful those were to put the little wire through there. And so, it's definitely been like relearning those kind of things. So I was like, okay, so 15 on the right, 20 on the left, or 24, and then 24 in the groin. I haven't done many groin lines, it's been a while. Like, it's just different. And then the vessels are all calcified. So like when you look at it on ultrasound, you're like, wow, like this artery I have to really poke to get into it. And then there's a shadow effect from the calcium, and you're like, this is unbelievable. So it's definitely a learning curve. We have an adult hospitalist that actually, a medical hospitalist that's rounding with us in the mornings, so that like on the pediatric unit, there's some, help around it. Cause you're like, what's a NSTEMI? And like, what is this, EKG showing? And should I be worried about these PACs? And so I think there's a lot that, it's like every single day, all the time, you realize that, wow, these are not kids.
Thank you guys so much. It's so incredibly inspiring to just listen to everything that you've learned and all that you're doing. And just thank you for taking the time to share it with all of us. I think this will be an incredible resource for pediatric surgeons and others everywhere. I just wanted to give everyone a chance to kind of make a closing comment if there's anything that you wanted to talk about that you haven't had the chance to mention, or kind of just like what's your one thing you'd recommend to people who are maybe a few weeks or days behind you in this process?
I guess I'll start, and I will say, gather your team. And that, I think, has been one of the most amazing things to watch, is the coming together of people from all different areas of the hospital to work together. I do think it's important, you have to balance experience with people who are used to working together. So the fact that I think initially some people had some reservations about a unit run by pediatric providers taking care of adults, but you have enough people who have taken care of adults and you bring in help. So you have adult hospitalists to help you manage the medical side, but don't discount the fact that you're used to working with these people and you trust each other. And I think that's been a huge component. It is emotionally exhausting, as well as physically exhausting. I think taking care of these patients, you start from the moment you walk in for the 12 hours or however long that you're there. So I think making sure that you are taking care of the emotional and physical health of everybody who's working on that unit, and making sure that there are resources for that, and making sure that you're getting adequate sort of rest and mental health rest when you walk away, because it's exhausting and it's really stressful. And I think sort of keeping an eye on that aspect of the care for everybody who's on the unit. But it's been amazing how much people have stepped up and been willing to kind of work outside of their comfort zone and take care of this absolutely unbelievable need for critical care that I've never experienced in my medical career, and I hope to never again. But it's been pretty amazing to see how quickly, the fact that you can convert a pediatric inpatient ward into a 50-bed ICU in the matter of about a week and a half or 2 weeks, and just because that's what needed to be done. So people figured out how to do it.
Yeah, I would say my advice would be to get involved, because I was really scared. I was scared for myself. I was scared for my family. I wasn't sure I knew enough about how to take care of them. I had a lot of anxiety going into this, what's going to happen? How's it going to work? The first night I came out and I was like giddy. It was like a sense of relief. Like, gosh, I'm actually doing something now. And it's been, to me, now that I'm a few days into it, I feel better, actually. I feel less anxious. I feel less scared. I have my little, what do I do to like get home so that I don't bring it home? Like the 80 million times I wash my hands, and like, how much soap I've used, but like, I think that once you get into the routine, like, you know, at the end of the day, as pediatric surgeons, we're doctors. And it's like, we got this. This is kind of our purview. We're used to taking care of adults. You're used to being put into situations you've never seen before. We do that every time. Like every diaphragm I do seems to be different. Every TEF is different. Like we're used to that process. We're used to being in situations that we're somewhat unfamiliar with. We're used to having an N of 3 and being okay with that. Like that's us. Like that's innate to who we are. And like you don't quite realize it until you're put into that situation. And then you're like, oh yeah, like I can figure this out. This is okay. I will be okay. And I think for all the people listening in, I would just say like get involved and like just go for it, because it's not as scary and it's actually more rewarding once you get going. And so if you have the opportunity and you see that there's a need in your community, I would say go for it, because anything you're doing is a skill set that they otherwise don't have.
Thank you, Samir. Marge, did you have anything else you
just wanted to, no, I just wanted to thank Meghan and Samir. I learned a lot, and actually I'll impart some of the things. I'm taking notes, as you probably saw, impart some of that knowledge to our adult critical care people. I mean, there's, you know, I think we have about 35 ICU cases, 35 to 40 ICU cases, because I missed the command control debrief, you know, the morning one. To participate here, but this is an incredible amount of knowledge. Thank you so much, and you know, thank you for sharing, and please take care of yourselves.
Happy to help as other people sort of begin to navigate this. I mean, we're certainly not the experts, but we're, you know, a couple weeks ahead, and yeah, happy to share what has worked and what hasn't worked. And we are, you know, just two people in a very big machine taking care of these patients. So certainly available anytime.
Thank you, everybody, so much, and just stay well and stay safe and keep doing great things. Thank you.
Thank you.
Thanks, Loren.
Thanks, David.